Hello everyone, this is Shad Reis from Detroit Medical Center. This is Arch 2022. With me is Dr. Nmf Itw Arch. She's Director of Heart and Vascular Structural Heart Program at the UVA. Nmf, always nice to see you.
Absolutely,
I know you
Chatty.
since fellowship,
Yes.
which is like, it's been like yesterday. Time fly. Now you became a Director of the Structural Heart Program at UVA. You're giving a talk about mitral valve. It's a very complex valve, it's hard to understand, but there's a lot of technology happening now. Can you kind of fill us on what's happening?
Sure. Always good to see you, Chatty, and thank you for having me. You know, it's interesting. We just, in the last week or so, celebrated the 20th anniversary of the first TAVR procedure performed in man.
Yeah.
And yet here we are in 2022, and we're still talking about the emerging technology of transcatheter mitral valve replacement, or TMVR. And you know, it's interesting that, you know, everyone's sort of asking, why don't we yet have the TAVR equivalent, if you will, of the mitral valve?
That's right.
And you know, when we look at the mitral valve, it's sort of a very different beast than aortics. You know, with aortics, as you know, we have sort of a fixed valvular issue leading to pressure hypertrophy. But on the mitral side, we have a very complex mitral valve apparatus, which includes the valve, the leaflets, the subvalvular apparatus, and then more importantly, it's the interaction of that entire apparatus with the left ventricle. And because of that very dynamic interaction throughout the cardiac cycle, along with geometric changes of the mitral valve annulus itself, it's D-shaped, there's usually not a fixed, rigid anchor. Because of all of those technical and anatomic considerations, along with, once we put a prosthesis, will it affect the outflow tract in the LV? Because of all these reasons, there have been many challenges for developing the true, if you will, you know, mitral valve or TMVR, the TAVR equivalent, if you will, of the mitral. And so in the last several years, we've sort of had two major transapical platforms, and they kind of remind us really of our initial days with TAVR from a TA transapical TAVR standpoint, really. We have two different devices at the moment that have the most data, one being the Medtronic Intrepid device, and the other being the Abbott Tendyne device. Both have unique features to each apparatus, but in essence, they're both sort of large transapical approaches that are delivered, you know, under almost surgical-like conditions.
Correct, yeah.
It's really not truly, you know, percutaneous from that standpoint.
Right.
We thus far have 30-day results for both Tendyne and Intrepid. We also now have 2-year data on the first 100 patients that have received the Tendyne TMVR, which was presented at TCT last year in 2021. And so we're starting to gain information about those two platforms. But
It's very interesting to see that big lag in development and research in this valve, 20 years valve, TAVR, and now we're just catching up on that.
Right, and I think it's predominantly because of all those anatomic and technical issues that go into the actual deployment and the procedure, you know, of the mitral valve. So it's exciting to sort of start seeing some of the early data. But I think that the real game changer as we head into 2022 and beyond is going to be the involvement of a truly percutaneous transfemoral venous transeptal system to allow for us to make the device and the delivery system smaller and avoid transapical access, because as we know from all of our data, whether it's from the TAVR literature or from our mitral literature, exactly, the transapical access just has such increased morbidity and mortality.
So it's a matter of time, hopefully, new iteration will develop. Now let me ask you this, I want to shift gear, stay in the valve, on the mitral valve, is about training. Now you trained for 1 year, you dedicated 1 year of training for structural. But for sure you learned now in the job, I'm not sure, similar, maybe even more stuff.
Oh,
correct?
100%. That's such a great question, because in such a vastly expanding, evolving, very dynamic field that we're in structural, we are constantly learning new protocols, new devices, every almost sometimes couple weeks to months. And so there's no way that 1 year of training can encompass all of that. What I would say for structural fellows that are out there is that you learn as much as you can about everything in that year, including the fundamental concepts that you can then apply to the new technologies. So for example, the transfemoral platform for Intrepid has now become available that we're investigating. And when we think about the concepts that we utilize in, for example, transcatheter edge-to-edge repair with MitraClip or Pascal, the concept of trajectory, positioning, and integrating 3D echo with what we want to do with the valve also translates into that same sort of concept of when we have a transfemoral transeptal delivery system for the Intrepid valve.
Wow. Well, a lot to learn and a lot more to come.
Absolutely.
Well, thanks, Dr. Soni, for your time.
Absolutely,
really appreciate
Shadi.
it for shedding some light on the mitral valve. Please watch this video and others on the Arch 22 YouTube channel. This is Shadi Reyes from Detroit Medical Center. Thanks again.
Thank you for having me, Shadi. It's a pleasure.